Hello, we're here for eCancer TV in Copenhagen for the prostate cancer debate. I have three esteemed expert colleagues with me this afternoon, and in fact between us we form a very nice multidisciplinary team. Now, we've had some excellent discussion in the prostate cancer debate over the last few days, and I'd like to ask Louis, first of all, what's your take-home messages on the use of docetaxel chemotherapy for hormone-sensitive disease?
Okay, I think everybody agrees among the experts, and now when I talk about the experts, it's across the urologists, the oncologists, the clinical oncologists, even maybe the people who are involved in basic science, that chemotherapy has a new role in prostate cancer. What we learn is that chemotherapy, if you start chemotherapy in M1 patients at the earlier stage where it still is hormone sensitive, we can get much more advantage for the patient. Means something in the range between 10 and 15 months of increase in median overall survival. So this is a new, I wouldn't say it's a new idea, but it's the confirmation of old ideas that we had. We knew that cancer is a heterogeneous disease. We knew that we have to attack different populations. We didn't know if chemotherapy combined with hormone therapy could work in these patients. Now we know it does work. This is the main message. Of course, these are the main results, but then we have to apply that in daily clinical practice. So I think in this meeting, we also debated a lot, which are the characteristics of the patients that make us to feel comfortable with this decision, or whether some patients we still have to think about other options besides chemotherapy at the beginning, particularly low volume disease and so on. So I think this is clear for me, and I think it was very well accepted among the audience.
I think it's provided quite a big debate, isn't it, with the three main studies and the charted study distinguishing between high volume and low volume metastases, with high volume having a survival advantage. Stampede recently showing a survival advantage of up to 22 months for people with M1 disease. Has that changed your practice, Peter? Has that?
Definitely. We were already changing the practice when we have these new hormonal therapies and also the discussion on chemotherapy later on towards a more multidisciplinary. But still, in the beginning, we treated these patients by urologists. Now, with the implication of the results there, which were convincing enough to offer even earlier docetaxel, that is a big change in the practice of urologists in treating advanced prostate cancer, yes.
And has it changed your practice, Louis? Which group of patients would you treat?
I can tell you one thing. When the Chartier trial was presented at ASCO, the first thing that we did in our department is to call our colleagues from urologists and let's go and have a meeting together to discuss this, okay? And so the urologist asked us, so do you want to now receive all these patients to chemotherapy and all that stuff? Okay, so it was a live discussion. Then we had the opportunity of having a live Chris Sweeney at our division also to discuss the results. And now came Stampede. So it's no doubt that we start to do that, and we do that for most of the patients. I can accept that some patients with low volume, and if you look for NCCN guidelines, it's clear there that maybe patients with low volume, it's not straightforward that should offer to them chemotherapy at front. I can accept that for patients with low volume that you can predict they have a very high response to hormone therapy. Sometimes they will not go to the option for chemotherapy. But patients with high volume, we cannot miss the opportunity. And definitely we should offer them to those patients the chemotherapy. So it changed our practice, definitely.
I think the Stampede study initially, when it was designed, had 6 arms, and obviously docetaxel was one of the arms. Zoledronic acid and celecoxib individually were other arms and didn't show any advantages over ADT alone. But at GU ASCO this year, or just this month, the biggest surprise to me was that the Stampede trial has shown that zoledronic acid and celecoxib together, given for hormone-sensitive disease, has a survival advantage. Now, Romano, could I ask, why should that be?
Yeah. Well, the choice of celecoxib and zoledronic acid was, I should say, laboratory driven, because we know that COX-2 inhibitors like celecoxib are able to inhibit several, I should say, cellular processes like angiogenesis, like proliferation, and this happens through the inhibition of prostaglandin synthesis and other mediators of cellular proliferation. So their evidence is mainly coming from the laboratory on the inhibitory effect of celecoxib on cell proliferation, and also COX-2 inhibitors has been used for the chemoprevention trials in colorectal cancer. So there is quite strong evidence of the role of the COX-2 inhibitors, not only in the inflammation processes, but also on cell proliferation effects. So combining the celecoxib with the zoledronic acid, which is known also for the inhibitory effect on bone resorption, but not only, because zoledronic acid is able to inhibit the farnesylation, which is a typical post-translational modification of proteins, and through this effect it is able to inhibit the farnesylation and the biological activation of many oncogenes of the RAS family. So combining together these two drugs, we can obtain inhibitory proliferation of cancer cells. So I'm not surprised by this evidence. It comes from the clinic and it comes from the laboratory also.
Thank you for that explanation. That's brilliant. Louis, what do you think about the side effects?
I mean, I knew about this lab work because we were interested a few years ago to test the effect of COX inhibitors in bone metastasis. You have to think about that most of these patients has bone metastasis. There is also some evidence that these COX inhibitors can help to inhibit bone resorption levels and so on. The question is on the practicality. Are we going to use zoledronic acid in patients when in STAMPEDE trial, zoledronic acid did not add survival or even decrease SRE's evidence in hormone sensitive? Of course, there is a role for them in patent resistant, but not in hormone sensitive. So are we going to prescribe zoledronic acid plus celecoxib, thinking that this will solve the problem of the advantage on survival on these patients? I think we still are not confident. We need to be more convinced. Maybe, I don't know if other trials will bring this information or not, or more data from the lab to tell us why this worked so well in STAMPEDE.
Peter, will it change your practice, or would you have concerns about toxicity that were voiced at GU ASCO?
No, not too much. I think the design of the STAMPEDE study is such that you have combinations there, and one combination we don't have to forget is hormonal therapy. So the effect apparently of hormonal therapy in combinations with these agents or with chemotherapy, there is a kind of a synergistic effect apart from the selection of cells that have hormone responsiveness and the unresponsive cells de novo. I think this synergistic effect also, with the opportunity within STAMPEDE to combine it, for instance, with radiotherapy, you see that there is something ongoing. And hormonal therapy, standard hormonal therapy, is still a big option there. So the combination of treatment to offer, apart from the toxicity, will be shown there in STAMPEDE also.
So,
if you allow me, I think we have also to think about, there are some cardiac events with the COX inhibitors that we know. And we know that cardiac problems and death due to the cardiac problems is one of the competing factors for death in these patients, even with the advanced stage. So we think we have to be careful not to go just adopt this strategy of putting all patients on celecoxib and that dosage, because we don't know yet what is going to happen really for the safety on the cardiovascular side, and if you're going to do that long term for those patients. I think so. That's my opinion.
Thank you. It certainly provoked a lot of discussion at the meeting, and indeed here between the four of us. And I'm sure this is going to continue to be discussed, and there's obviously further factors that we all need to consider. But moving on a little bit, there's been discussion today about M0 disease. Peter, do you think M0 disease exists?
So M0 is apparently radiographic evaluation standard with bone scan and CT scan, and it's clear, and it's the conclusion that it is suboptimal, definitely suboptimal. So with the new PET scanning or MRI, there's a better imaging. And then you become aware of the fact that although these patients were on traditional CT scan and bone scan negative, about 30 to 40% of these patients have these minimal metastasis when you detect them on other measures, like the new PSMA scanning, for instance. So it's more that M0 should be considered as minimal metastatic advanced prostate cancer than it is really the M0. The trials there are ongoing, and I think finally we will consider them as an earlier phase of the treatment of castration-resistant prostate cancer, and not mentioning them the M0 indication. So that will be a change, but definitely these trials should be done to see if in that minimal metastatic patient population of castration-resistant prostate cancer it has an effect, and I'm confident that it will show an effect.
Because they become low volume, don't they? Really, as to the low volume. We've also heard, Louis, that the FDA is accepting metastasis-free survival in this group of patients. Do you think that's a valid endpoint for some of these studies?
I think so. I mean, we are clinicians, we have to deal with the hospital administrations and the regulatory issues and so on. But if I was a patient and someone asked me, do you think that the time until metastasis appear to you is important or no, I'll say definitely yes. Because if you live with the knowledge that you have a metastatic disease, it's totally different to your life, I think so. Changed a lot. So even from, let's say, quality of life perspective, it's so important. So I think we should accept that this will be an important endpoint in the future. If that will be translated on survival or not, I don't know yet, but I think will be an important point. And everything that we can do in our hands as clinicians to participate in clinical trials that can provide prolongation of time without metastasis, I think will be important, definitely.
Thank you. So I think we await the results of those studies with huge interest, and they could make quite significant differences to the way that we're managing men with prostate cancer at the moment. One of the other areas of great interest has been biomarkers and the term a liquid biopsy. Now, Romano, could you explain that to us a little bit more? And there was a study presented by Howard Scher at GeoASCO again, and would you be able to enlighten us a little about that?
Sure. We can call them, instead of those approaches, instead of liquid biopsy, we can also say just blood-based biomarkers.
Liquid biopsy sounds so nice though, doesn't it?
It's nice anyway. It's of course. And well, there is a strong interest on the application of less invasive diagnostic procedures. Those are important not only to make a diagnosis, but also, and even more important, to monitor the progression of the disease. We use this approach, for instance, in non-small cell lung cancer. It is quite established because there are secondary mutations in the target that are associated with drug resistance. And so it's very important to monitor the occurrence of these mutations in the blood and the liquid biopsy approach, because we can change treatment, because we have more specific drugs for mutated targets. And so this makes the whole approach more rational. We can probably do the same in prostate cancer, because we have strong evidences that there is a family of splice variants of androgen receptor. The more popular, the most popular, I should say, is ARV7, but this is not the only one, because ARV7 is probably 50% of all splice variants. The other variants are also associated with resistance to hormonal treatment. And for this reason, we should be able to monitor all the variants before saying this patient is resistant due to this reason, this specific reason. And the laboratory approach is feasible. We are trying to make the laboratory approach to the screening of this variant more reliable in terms of technical platforms, and also less expensive, because of course there is the cost that should be considered. The splice variants are not the only reason for resistance. There are additional reasons for resistance. Also, the androgen receptor can change due to mutations of the receptor itself, not just for splice variant, but for mutation polymorphisms in the gene sequence that can change the structure, the organization of the target itself. So if we put together this knowledge, we should be able in the next years to have reliable tests to screen for the occurrence of the secondary mutations associated with resistance. The second problem will be the standardization of the clinical condition, because I mean, we know that the volume of the disease, the kind of treatment the patient receives can affect the amount of the mutated alleles in the blood. So there is not only a technical problem, but there is also a clinical problem. When and in which condition to apply this kind of approach, which is very promising and should be explored in the next years.
Thank you. I think that's, sadly, I think we're going to have to end here as we're out of time, but I'd like to say an enormous thank you to my colleagues for a very interesting discussion that I'm sure will continue when the cameras stop rolling, and hopefully this has provoked some questions to all of our audience, who I would also like to thank immensely for joining us this afternoon. Thank you so much.